Hello, hi everyone. The topic of today's lecture is attachments in removable prosthodontics. Okay, so this is the last lecture of the series of lecture for you guys, and after this, hopefully, you will be starting your seminars from the next week. So, in case someone is getting confused, the topic originally was intracorneal retainers and precision attachments. uh, I felt this topic is wrong because precision attachments and intracorneal retainers all come under attachments. And when we talk about attachments, talk about precision attachments, we talk about semi-precision attachments. So I modified it, and moving forward, the objectives are you should be able to define and classify precision attachments. You should be able to describe the attachment design of the intracorneal as well as extracorneal attachments. You should be able to describe the advantages, disadvantages, the indications and contraindications of precision attachments. And finally, you should be able to describe the attachment design for studs, bars, and magnets. Okay, so coming to definitions first. So these definitions are all taken from Glossary of Prosthodontic Terms, edition 9, that is GPT 9. So first, let's see what is an attachment. An attachment is one second, let me just get the mouse. uh, okay, so an attachment is a mechanical device for fixation, retention, and stabilization of a prosthesis. It is also a retainer connect consisting of a metal receptacle and a closely fitting part. The former, that is the receptacle, is known as the matrix and is usually contained within the normal contours of a crown, and these may be intracorneal or extracorneal attachments. Okay, so intercorneal attachments are any prefabricated or custom made attachment for support, retention of a fixed or removable partial denture. The matrix and matrix components are positioned within the normal contours. That's why it's called as an intracorneal attachment, as you can see in the pic over here. So intracorneal attachments are confined within the normal contours of a tooth or a crown, whereas extracorneal attachments are any prefabricated attachment for support and retention of a removable dental prosthesis, and the receptive and the retentive component, that is the matrix and patrix, are positioned outside of the normal contours of the crown. That's why they're called an extracorneal attachment. So here matrix is the receptacle, that is the female portion, and patrix is the part that fits closely into it, that is the male part. Okay, so to avoid confusion, so what is a friction attachment? Friction attachment is also known as a precision attachment. These friction attachment or precision attachment is a precision or semi-precision attachment that achieves retention by metal to metal contact without any springs, clips, or any other mechanical means of retention. So there is a precision attachment means both the parts of the attachment are metallic and they do not have any resilient component in between them, whereas a semi-precision attachment is a lab fabricated rigid metallic matrix of a fixed or removable partial denture that fits into the matrix, that is receptacle, in a cast restoration. Okay, so these may be used for fixed removable bridges like Andrews bridge, or these may be used in cast partial dentures, or these may be also be used for the retention of a tooth supported over denture. So they are designed to replace the basically the occlusal rest, the bracing arm, the direct retainer of a conventional clasp assembly in a CPD denture. So this is what I am talking about, intracorneal and extracorneal attachments. Okay, so what are the indications for these attachments in removable prosthodontics? First is in the aesthetic zone. So when we use a type of attachment such as an intracorneal or extracorneal, precision or semi-precision attachment, there is no need for clasp, there is no need for occlusal rest, there is no need for a reciprocal arm. So the clasp metal display is not there. So it's obviously aesthetic. It redistributes the forces, that is these attachments are very rigid and they are closely approximated to the tooth, so and they balance the forces. They minimize the trauma to the soft tissues by redistribution of the forces between the tissues and the teeth. They minimize the trauma to the soft tissues adjacent to the abutment teeth, that is in the edentulous area. They control the roding and rotational forces because these attachments usually move in a vertical direction, so they minimize the rotational forces with the exception of a stud attachments like a locator or a ball attachment. Okay, they can be used when non-parallel abutments are also present. They can be used for segmenting long span bridges when there are too many long bridges, especially if you remember we talk about pyre abutments. When you have a 5 unit bridge in the maxillary or mandibular arch, where say you have first premolar is missing and the first molar is missing and the second premolar becomes the pyre abutment. So in such cases, to avoid detrimental forces to the pyre abutment, we generally use a split connector. So basically, split connector is nothing but an extracorneal or intracorneal attachment added onto the second premolar in case of a pyre abutment. And for future salvage efforts, they improve the retention. Obviously, retention is much better than with the clasp assembly. They can be used as movable joints in fixed movable bridge work, like in Andrews Bridge, where you have large pontic area, large edentulous defects, and you want to go with a fixed bridge. So in such cases, the edentulous portion, you fabricate a separate removable fixed partial denture or acrylic denture. So this is known as an Andrews bridge. They can also use as stress breakers in free and saddle areas like the Kennedy's class 1 and class 2 situation. Intracorneal attachments are as effective as direct retainers, if not better. They can be used as connectors in sectional dentures. So sections of fixed process may be connected with intracorneal attachments. They can be used to lock connector joint saddles in the opposite arch as a contingency device for extension or conversion of existing dentures where fixed partial dentures are contraindicated due to periodontal disease, and to retain hybrid dentures. Okay, so hybrid dentures are basically your overdentures placed on implants or on remaining abutment. Okay, contraindications are of course in patients who are sick and senile, that is patient who are not in their mental health capacity or do not have enough strength and mental alertness to use and maintain care for these appliances along one precise path of insertion. The patient must possess an average degree of manual skill. So if there is more than one path of insertion, it is difficult for the patient to insert the cast partial denture or an overdenture. Patient with severe periodontal disease, because these, as I mentioned, these attachments are very rigid and they may cause further damage to the periodontal complex of the periodontally compromised abutment teeth. So in such cases, we should not use them. Patients have high caries index or poor oral hygiene status, or who cannot maintain regular oral hygiene, in them it is definitely contraindicated as a result in caries of the abutment teeth under the attachment. Okay, and when there is inadequate space, there should be enough vertical space available for the placement of the attachment and its receptacle, that is the receptacle, the fitting portion, and the framework. So we need sufficient space for all of these. Okay, so what are the advantages? As I mentioned, there are no visible clasp or rest, so of course it is definitely more aesthetic. So it is more acceptable for the patient to have a removable type of prosthesis without any clasp. As you can see here we have two abutment crowns retaining an attachment. So what type of attachment is this? This is an extracorneal attachment. This is the OT cap. So this is the extracorneal attachment, and this is the male portion here, and the receptacle with the housing is retained inside of the removable partial denture. You can see here this is a Kennedy's class 2 situation in which first and second molar have been missing and they are being retained with the help of a extracorneal attachment on these two abutment crowns. Okay, so compared to conventional class partial dentures, they give better retention and stability, and they are less liable to fracture than class. So class, one of the main disadvantages of class is if the patient uses too much force, or the CPD falls down, or if you try to manipulate the clasp, there is high chances of clasp fracture. Okay, which does not exist with the extracorneal or intracorneal attachments. And depending, if you want more retention, we can use uh, you know a silicone ring of a more higher rigidity. So depending upon the color coded silicone rings, we can improve the retention from very high to low retention. So they offer better retention as compared to your conventional okay. Lateral forces are minimized during insertion and removal because they have a precise fit between the patrix and the matrix. So lateral and rotational forces are minimized with the help of these attachment. This is a stud type of attachment, that is a ball attachment with a housing. Okay, so this is the patrix and this housing is the matrix. So this is, as you can see, the pink color here is the silicone ring used inside the housing. So they move only in a vertical direction, and controlled lateral movements are there. So they also offer cross arch stabilization and load transfer on the other side of the arch to the abutment teeth. So here we see a matrix, a patrick. This is a precision attachment because there is no resilient silicone lining or spring or clip inside. So this is a metal to metal contact. So these are prefabricated metallic attachments which are just waxed up into the wax contour or wax coping in the laboratory by the technician. So these are already prefabricated. That's why these are. So in case of distal extension based removed partial denture, they incorporate a stress breaker philosophy by using an intraconal extraconal attachment in a distal extension cavities class 1 and class 2. The stress is dissipated with the vertical controlled vertical movement of the attachment, and there, as we know, there is a resilient silicone liner inside the between the matrix and the patrick. So this dissipates the forces, uh, allows vertical and rotational movements to certain extent, and depending on the design and the resiliency of the silicone lining. So it works effectively in a tooth and tissue supported cast partial denture. So this is one example. This is an extracorneal attachment and OT cap, like I mentioned before. So this allows vertical and rotational movement because of the ball head design, and of course the silicone lining or the ring can be, or the sleeve can be changed to the desired rigidity. Okay, the clear silicone linings are the most flexible ones. Precision attachment provide better vertical support and better stimulation of the underlying tissues through intermittent vertical massage of the edentulous. Okay, so what are the disadvantages? Complexity of the design, complex principle and procedure of fabrication. So of course we know there are multiple components involved, they're highly precise, and they require a good level of expertise to be executed. Not any lab technician can do it. They are expensive because these are prefabricated either attachments or prefabricated patterns of attachments, so they are pretty expensive compared to your traditional CPD, and they require high level of technical expertise for successful fabrication. As I mentioned, because of the increased incidence of secondary caries, so the patient has to maintain a good level of oral hygiene. Okay, and since the tooth may be, need to be extensively prepared to receive the attachment, especially in case of an intracorneal attachment, so this is also a drawback. The attachment are subject to wear because, as I mentioned, semi-precision attachments have a intermittent resilient element, like it could be a ring, it could be a silicone sleeve or a clip. So these wear over time, so these need to be replaced and maintained. So this is again an added disadvantage. Okay, coming to classification, like we have already seen in definition, we have precision attachments and semi-precision attachments. Precision attachments are already prefabricated, whereas semi-precision attachments need to be fabricated in the laboratory. Usually, they are available in burnout castable plastic patterns, which are just waxed onto the coping and then cast in the laboratory with the either nickel chromium or cobalt chromium. Okay, the precision attachments are generally intracorneal and non-resilient, so they are just metal to metal contact. Semi-precision attachments are intracorneal, extracorneal, radicular, intraradicular, you name it. All varieties are available in precision attachment. Now coming back to precision attachments, their advantages include they have consistent quality because they are prefabricated. There is controlled wear because there is only metal to metal contact, so there is no intermittent element. So there is less chances of wear. They're easier to repair, and these parts are interchangeable. Okay, now some examples of wrist attachments are a roach type of ball slider. So this is the matrix receptacle, and this is a ball attachment, which is known as a roach type of ball slider. So this can be attached on the distal of the abutment teeth in case of Kennedy class 1 and class 2. And also we have McCollum slider. So this is like your normal, like how we have sliding windows, aluminum windows in our condos or apartments. So something based on the similar concept. So these can be included as an intracorneal attachment because they do not occupy much space. You can see again there is no intermittent element other than metal only. So these can be used intracorneally. And we have stern latch. This is also used intracorneally. One part is waxed onto the crown, another part is retained inside the removable partial. So this is one type of semi-precision attachment, that is a burn OT cap. So the here we can see This is the ball type of attachment. It is waxed onto the uh, coping or wax pattern on for the crown. So it is attached onto it using a parallelometer. So we have a specific mandrel for this which is attached to the parallelometer. Parallelometer is basically a surveyor instrument, so it is attached using that, and depending on the path of insertion we have chosen for the patient's arch. Okay, and after casting it looks something like this. Ceramic is layered onto the crowns, and this is the metal uh, casted semi-precision attachment. Okay, so here the matrix is attached to the crowns. The matrix, that is the coping, the housing, it retained inside the your RPD. So here we can see the here this is a both this is a bit of both precision and semi-precision attachment. Why? Because first we have the plastic pattern, so this becomes a semi-precision attachment, and then we have a OT ball attachment which is prefabricated. You can see gold plated, which is then screwed into the semi-precision cast pattern. So this is a combination of both semi-precision and precision. Okay, so and then the once the housing is placed in the mouth, the crowns are cemented, the housing is placed onto the patrix, and then the impression is taken. The impression is poured in a refractive material, and on top of that a wax pattern, wax up is made of the housing and the minor connectors which will retain inside the denture. After casting, this is the housing with the minor connector in the chrome cobalt alloy, and these will then be processed in or picked up inside the patient's cast partial denture. Okay, now coming to some examples of stud attachments. So stud attachments are basically all the attachments other than your bars, other than your magnetic attachments. Okay, so all the locator attachment, the ball type of attachments, this OT cap, all these things are all come under the stud attachment. There are many companies that manufacture attachment like Rhine 83, Priet, and Era, and some few more companies. So all these type of attachments which are protruding are or a snap-on mechanism are known as a stud attachments. Okay, so here we see ball attachment, which is this is an intraradicular attachment, which that means retained tooth are root canal treated, and then same as your post and code, these are waxed up onto the uh, post space, and then they are cast in metal like this, coping with the ball attachment or the stud attachment, and then the housing is picked up inside the patient's overdenture or a RPD or a cast partial denture. Okay, so and here again we see stud ball attachments on either side, and these we see on the teeth we have telescopic copings. Okay, one coping is uh, here and another coping is over here, and over these additionally a housing is made with two more copings which are retained inside the denture. So these telescopic copings become the precision attachments, and these on either side, the ball or stud attachments, they become the semi-precision attachment because they have been waxed up into the wax pattern of these copings. Okay, so another attachment here is a locator attachment, which is again a radicular interradicular attachment. We can see it goes into the post space, and it is luted into place with a resistment or a GIC. And here we have a ball attachment, titanium ball attachment, which again is luted into place inside the post space. So both of these are if you just talk about the ball and the stud, these are prefabricated attachments, and the housings are also prefabricated, but they have an intermittent silicone lining. It may be clear or it may be one of these different colors. Okay, depending on what level of retention we desire, we can anytime change these retentive caps or retentive elements. So this is again becomes a semi-precision attachment. Okay, so coming to bar attachment. So first bar attachment that we'll be seeing is a header bar. So as the name suggests, it is a bar that connects the two abutment teeth or the two implant copings. Okay, so header bar is in shape, it is similar to a keyhole shape. That is, it is semicircular on the top and a rectangular or beam shape at the bottom. So here we have a plastic pattern for a header bar. We have a housing, a silicone clip, and we have a housing that retains this silicone clip. Okay, so and this green color is a processing clip. We can over here in the next page. So there are two ways to fabricate it. Either it can be fabricated entirely in the lab, or the silicone clip and the housing of the clip can be picked up inside the patient's mouth. That is, the bar is first attached or cemented onto the abutment teeth or to the implant, and then the clips and the housing are placed on top of the bar at the desired place or location, and then in the patient's denture which has been previously fabricated, we just pick up these housing with the help of a self-cure acrylic. In the lab, they can be processed by duplicating the after cementation of the bar. The impression is taken, and this impression is posed in a refractory material. That's why you see the cast is very rough. And on this refractory cast, the green color processing spacer is first placed. Over that, the housing is placed, and this is processed inside the denture, like how we process our denture the regular way, or by Pre-Ed Corporation. And this is an OT bar by the Rhine 83 Attachments, which is an Italian based company which specializes in precision attachments. Okay, so here we have a different design. We have a inverted U-shaped design with a channel running along the length of the bar, and this bar is also available as a semi-precision attachment, that is a prefabricated plastic pattern. Then we have the different color coded silicone rings depending on how much retention we need. And this is the plastic housing that needs to be cast in metal. So this is the bar which is cast with the copings of the on the abutment teeth, and then this is the housing with the uh, silicone clips processed inside the denture. Okay. So now coming lastly to magnetic attachment. Magnetic attachment usually have a stainless steel. They basically consist of two parts. They have a stainless steel box. The retentive force will depend upon the type of the magnet that is being used, whether it is samarium, cobalt, or neodymium, iron, boric alloy magnet. These are not the regular magnets that we get in DIY shops. These are metallic alloy magnets. Okay, and usually they are flat or dome shaped, and they have two portions, and they are available in different sizes, depend on different retentive forces from 2.5 newton to 4 newton. The advantage of the retentive forces do not change with time, because with the other attachments, the clip or the silicone clip or the retentive clip may become loose over time or wear out, but magnets do not lose their magnetic property or retention over time. Disadvantages are there's no systemic effects, but problem in case of a magnetic, when patient has to go for a MRI or magnetic resonance imaging, or a patient has allergy to metal. Fields of application is used in prosthetic rehabilitation, for the retention of overdenture, for the retention of implant supported overdentures, for the retention of extraoral processes like your ear processes, your nose processes, your orbital processes. So there are many usage of magnetic attachments, and most common type, one of the example is a magfit. Okay, so this here's an example where a magnetic attachment is being used as an intraradicular attachment. So one part of it is attached to the root, the second part is attached to the inside the denture, retained inside the denture. Okay, so basically it's the same phenomenon. The two opposite poles, that is south and north pole of the magnet, they attract each other, so they are usually placed up in this fashion opposing each other. Okay, so that brings us